Question 1. A 72-year-old patient with chronic heart failure and diabetes presents with shortness of breath, crackles, and blood glucose of 42 milligrams per deciliter. Which nursing action is the highest priority? A. Administer IV dextrose for hypoglycemia. B. Apply oxygen and raise the head of bed. C. Assess airway and breathing before giving dextrose. D. Notify the provider of both findings simultaneously. Answer. C. Assess airway and breathing before giving dextrose. Rationale. In a patient with respiratory distress, airway and breathing come before circulation or hypoglycemia correction. Option A addresses glucose, but not the immediate threat, respiratory failure. Option B is supportive, but follows airway assessment. Option D delays intervention. Question 2. During postoperative care, a patient's urine output decreases from 50 milliliters per hour to 15 milliliters per hour. BP drops to 88/52 millimeters of mercury, and heart rate rises to 118 BPM. The IV line is infiltrated. What should the nurse do first? A. Start a new IV and give prescribed fluids. B. Notify the surgeon of low urine output. C. Insert a Foley catheter to verify output accuracy. D. Elevate the extremity with infiltration. Answer. A. Start a new IV and give prescribed fluids. Rationale. Restoring intravascular volume is the immediate life-saving priority. Urine output drop plus hypotension plus tachycardia equals hypovolemia. Option B is secondary. Option C doesn't fix the cause. Option D is correct for infiltration but delays fluid resuscitation. Question 3. A patient with head trauma suddenly has BP 180/60 millimeters of mercury, heart rate 48 BPM, and irregular respirations. What should the nurse do immediately? A. Administer antihypertensive medication. B. Elevate head of bed 30 degrees and notify the provider. C. Increase IV fluids to maintain perfusion. D. Call for rapid response and prepare for intubation. Answer. D. Call for rapid response and prepare for intubation. Rationale. Cushing's triad indicates increased ICP and impending herniation, immediate airway management, and neuroemergency. Elevation B helps but is insufficient alone. Antihypertensives A. Worsen cerebral perfusion. Increasing fluids C. Worsens ICP. Question 4. A nurse notices a new order for IV potassium chloride 40 milliequivalent in 100 milliliters to infuse over 30 minutes. What is the nurse's best action? A. Verify renal function and administer via pump. B. Question the order and clarify infusion rate before administration. C. Dilute in more fluid and infuse slowly. D. Administer half the dose now and half later. Answer. B. Question the order and clarify infusion rate before administration. Rationale. Potassium 40 milliequivalent over 30 minutes is unsafe. Risk of cardiac arrest. Nurses must question unsafe orders. Administering A or diluting C without clarification changes order. Dividing dose D is unauthorized alteration. Question 5. A nurse caring for a septic patient receives these orders. 1 blood cultures, 2 antibiotics, 3 1 liter normal saline bolus. What is the correct sequence of actions? A. Antibiotics, cultures, fluids. B. Cultures, fluids, antibiotics. C. Cultures, antibiotics, fluids. D. Fluids, antibiotics, cultures. Answer. C. Cultures, antibiotics, fluids. Rationale. Draw cultures first to identify pathogen, then administer antibiotics promptly, followed by fluids to restore perfusion. Delaying antibiotics after fluids wastes critical time. Starting before cultures compromises accuracy. Question 6. A post-stroke patient has difficulty swallowing pills and coughs during meals. What is the most critical nursing action? A. Notify provider for swallowing evaluation before oral intake. B. Crush medications and mix with applesauce. C. Encourage small sips of water after each pill. D. Position patient at 90 degrees and continue feeding carefully. Answer. A. Notify provider for swallowing evaluation before oral intake. Rationale. Possible dysphagia, aspiration risk. Must stop oral intake until swallow study. Crushing meds or continuing feeding may cause aspiration pneumonia. Positioning helps, but doesn't address underlying risk. Question 7. A patient with pneumonia has SpO2 88% on 6-liter O2 via nasal cannula and increasing anxiety. What is the nurse's next best step? A. Switch to non-rebreather and reassess. B. Obtain ABGs before changing oxygen. C. Call the respiratory therapist for consultation. D. Prepare for possible intubation and notify the provider. Answer. D. Prepare for possible intubation and notify the provider. Rationale. Refractory hypoxia on high-flow O2 equals impending respiratory failure. Intubation prep and notification are critical. Non-rebreather, A, may temporarily help but delays escalation. ABG, B, can follow stabilization. Question 8. The nurse identifies ST elevation in a patient on telemetry who reports no pain but looks pale and diaphoretic. What should the nurse do first? A. Reassess in 15 minutes. B. Call rapid response and obtain 12-lead ECG. C. Check potassium level. D. Give sublingual nitroglycerin. Answer. B. Call rapid response and obtain 12-lead ECG. Rationale. Silent MI requires immediate ECG confirmation and emergency response. Nitroglycerin without confirmation may worsen hypotension. Waiting risks death. Checking labs delays life-saving intervention. Question 9. A patient develops hives and shortness of breath after IV antibiotic administration. What is the first nursing action? A. Stop the infusion immediately. B. Call the provider for antihistamines. C. Administer epinephrine IM. D. Apply oxygen and assess vital signs. Answer. A. Stop the infusion immediately. Rationale. Stopping the offending agent halts reaction progression. Then assess, call for help, and administer epinephrine or O2 per protocol. Giving meds first allows continued exposure. Question 10. During morning rounds, you find a patient confused, pale, with blood glucose 32 milligrams per deciliter, IV saline locked, and meal untouched. What should the nurse do first? A. Call the provider for glucose order. B. Administer IV dextrose immediately. C. Document findings and notify charge nurse. D. Offer orange juice to raise glucose. Answer. B. Administer IV dextrose immediately. Rationale. Critically low glucose plus confusion equals emergency. IV dextrose acts fastest. Oral juice D. Unsafe if altered LOC. Calling provider delays care. Documentation C. Is not priority. Question 11. The nurse notices the LPN administering insulin Lispro to a patient whose meal tray hasn't arrived. What is the appropriate nursing action? A. Allow administration. Meal will arrive soon. B. Stop the LPN and ensure the tray is present before giving insulin. C. Document after ensuring patient eats later. D. Notify the provider immediately. Answer. B. Stop the LPN and ensure the tray is present before giving insulin. Rationale. Rapid-acting insulin without food causes severe hypoglycemia. Nurse must intervene. Provider notification after safety action is appropriate, not before. Question 12. A patient with acute kidney injury has serum potassium 6.8 milliequivalent per liter and ECG showing tall T waves. What is the immediate nursing action? A. Give sodium polystyrene sulfonate. B. Place patient on cardiac monitor and notify provider for calcium gluconate. C. Prepare for dialysis. D. Restrict potassium in diet. Answer. B. Place patient on cardiac monitor and notify provider for calcium gluconate. Rationale. Life-threatening hyperkalemia requires immediate cardiac protection and provider notification. Dialysis or Kxalate time. Diet restriction is preventive, not emergent. Question 13. A nurse hears a UAP shouting that a patient fell in the hallway. On arrival, the patient is on the floor, complaining of hip pain. What should the nurse do first? A. Move the patient to bed to prevent embarrassment. B. Assess for injury before moving the patient. C. Call the provider immediately. D. Ask the UAP what happened. Answer. B. Assess for injury before moving the patient. Rationale. Assessing before movement prevents worsening injury, fracture spine. Moving first violates safety. Provider call follows assessment. Witness account can wait. Question 14. A patient with chest trauma develops tracheal deviation and absent breath sounds on the left. What is the nurse's best immediate action? A. Call the provider and prepare for chest tube insertion. B. Increase oxygen flow to 15 liters per minute. C. Place patient flat and apply pressure dressing. D. Administer morphine for pain. Answer. A. Call the provider and prepare for chest tube insertion. Rationale. Tension pneumothorax. Life-threatening. Needs emergency decompression. Oxygen alone won't fix it. Flat position worsens breathing. Analgesia delays life-saving intervention. Question 15. During blood transfusion, the patient develops chills, back pain, and dark urine. What should the nurse do first? A. Slow the infusion rate. B. Stop the transfusion and keep IV open with normal saline. C. Call the provider and discard blood bag. D. Administer diphenhydramine as ordered. Answer. B. Stop the transfusion and keep IV open with normal saline. Rationale. Signs of acute hemolytic reaction require immediate stop and saline line maintenance. Slowing. A. Allows ongoing hemolysis. Discarding bag removes evidence for investigation. Diphenhydramine. D. Inappropriate. Question 16. A patient post. Thyroidectomy suddenly develops hoarseness, difficulty breathing, and neck swelling. What is the priority action? A. Assess airway and prepare for emergency tracheostomy. B. Call the provider for antihistamine order. C. Apply ice to the incision site. D. Place patient in Trendelenburg position. Answer. A. Assess airway and prepare for emergency tracheostomy. Rationale. Airway obstruction from hematoma, life-threatening. Airway comes first. Ice and positioning are adjuncts. Antihistamine irrelevant. Question 17. The nurse receives morning report on 4 patients. Which should be assessed first? 1. COPD patient on 2-liter O2 SpO2 91%. 2. Post-op day 1 with pain 8 out of 10. 3. DKA patient with fruity breath. 4. Pneumonia patient with new confusion. A. COPD patient. B. Post-op pain patient. C. DKA patient. D. Pneumonia patient with new confusion. Answer. D. Pneumonia patient with new confusion. Rationale. New confusion equals hypoxia, life-threatening. DKA stable unless worsening. COPD 91% acceptable baseline. Pain needs management, but not priority. Question 18. A nurse receives an order for morphine 2 milligrams, IV every 2 hours, PRN pain. The patient's respirations are 8 per minute, unarousable to voice. What is the correct action? A. Hold morphine and administer naloxone per protocol. B. Give 1 milligram morphine to maintain comfort. C. Call the provider after giving medication. D. Wait until patient awakens to reassess pain. Answer. A. Hold morphine and administer naloxone per protocol. Rationale: respiratory depression, immediate naloxone, and hold opioid. Giving any opioid worsens depression. Waiting or delaying reversal risks arrest. Question 19. An elderly patient with advanced dementia pulls out a Foley catheter with the balloon inflated. What is the nurse's immediate action? A. Reinsert the catheter immediately. B. Assess for bleeding and urinary retention. C. Notify family and document incident. D. Apply restraints to prevent recurrence. Answer. B. Assess for bleeding and urinary retention. Rationale: assess injury before intervention. Reinsertion without assessment risks trauma. Restraints only if necessary after full assessment. Question 20. During shift handoff, a nurse reports giving a wrong insulin dose 1 hour ago. Patient's blood glucose now 44 milligrams per deciliter. What is the most appropriate immediate action? A. Administer IV dextrose and monitor closely. B. Notify provider after the next glucose check. C. Document and continue observation. D. Blame previous nurse for error. Answer. A. Administer IV dextrose and monitor closely. Rationale: patient safety first. Correct hypoglycemia immediately. Then notify provider and complete error protocol. Documentation or blame is secondary. Question 21. A septic shock patient remains hypotensive, mean arterial pressure 56 millimeters of mercury, despite receiving 3-liter crystalloids and norepinephrine at 0.4 micrograms per kilogram per minute. Central venous pressure is 10 millimeters of mercury, lactate 6.2 mol per liter, and urine output 10 milliliters per hour. What is the most appropriate next intervention? A. Add vasopressin infusion. B. Administer an additional fluid bolus. C. Increase norepinephrine dose to maximum. D. Start dobutamine infusion. Answer. D. Start dobutamine infusion. Rationale: the patient shows refractory septic shock with evidence of poor perfusion despite adequate preload. Central venous pressure 10. Dobutamine supports cardiac output and oxygen delivery. Vasopressin, A, can be added, but not before optimizing cardiac output. Question 22. A ventilated trauma patient suddenly has high airway pressures, SpO2 78%, absent left breath sounds, and tracheal deviation to the right. What is the nurse's immediate action? A. Manually ventilate and call for emergent decompression. B. Reposition the endotracheal tube. C. Increase FiO2 to 100% and wait for respiratory therapy. D. Obtain a stat chest X-ray. Answer. A. Manually ventilate and call for emergent decompression. Rationale: these are classic signs of tension pneumothorax. Decompress immediately before confirmation imaging. Delaying action can cause cardiac arrest. Question 23. A patient on dopamine infusion, 10 micrograms per kilogram per minute, for cardiogenic shock develops heart rate 145 BPM, PVCs, and BP 68/40. What is the nurse's best action? A. Stop dopamine and prepare to start norepinephrine. B. Decrease dopamine by 50% and observe. C. Administer amiodarone for arrhythmia. D. Begin rapid fluid bolus. Answer: A. Stop dopamine and prepare to start norepinephrine. Rationale: dopamine-induced tachyarrhythmia worsens cardiogenic shock. Norepinephrine offers vasoconstriction with fewer arrhythmic effects. Immediate discontinuation is essential. Question 24. A ventilator high-pressure alarm sounds, and the patient's SpO2 drops to 82%. Manual bagging is difficult. What is the nurse's next best action? A. Suspect tension pneumothorax and call for rapid decompression. B. Increase sedation and continue bagging. C. Check for mucus plug and suction airway. D. Switch to pressure control mode. Answer: A. Suspect tension pneumothorax and call for rapid decompression. Rationale: difficult manual ventilation indicates a physical obstruction or trapped air. Immediate recognition of pneumothorax prevents cardiac compromise. Question 25. While weaning a patient from mechanical ventilation, respiratory rate increases to 38 per minute, heart rate to 140 BPM, and SpO2 to 83%. What should the nurse do first? A. Reconnect to full ventilatory support. B. Administer bronchodilator. C. Increase FiO2. D. Encourage slower breathing pattern. Answer: A. Reconnect to full ventilatory support. Rationale: signs of acute weaning failure, tachypnea, desaturation, tachycardia, require immediate return to full support. Continuing weaning may lead to respiratory arrest. Question 26. A patient with massive hemorrhage is receiving rapid fluid replacement. Despite 4-liter crystalloids, mean arterial pressure remains 50 millimeters of mercury, and hemoglobin is 6.9 gram per deciliter. What is the priority intervention? A. Transfuse packed red blood cells immediately. B. Begin vasopressor support. C. Administer calcium chloride. D. Give albumin infusion. Answer: A. Transfuse packed red blood cells immediately. Rationale: oxygen carrying capacity must be restored in hemorrhagic shock. Fluids alone dilute clotting factors and worsen hypoxia. Calcium may follow to correct citrate toxicity. Question 27. A patient on ventilator suddenly desaturates to 75%, heart rate 130, BP 80 over 48. The nurse finds the ETT cuff deflated. What is the priority nursing action? A. Manually ventilate with 100% O2 and reinflate cuff. B. Increase PEEP setting. C. Reconnect ventilator and reassess. D. Call the respiratory therapist immediately. Answer: A. Manually ventilate with 100% O2 and reinflate cuff. Rationale: a deflated cuff causes loss of tidal volume and hypoxia. Immediate manual ventilation ensures oxygen delivery while securing airway integrity. Question 28. A patient with ARDS on high PEEP 14 centimeters of water develops JVD, tracheal deviation, and absent right lung sounds. Which action should be done first? A. Disconnect from ventilator and manually ventilate with 100% O2. B. Administer IV fluids. C. Increase sedation. D. Perform ABG. Answer: A. Disconnect from ventilator and manually ventilate with 100% O2. Rationale: high PEEP may cause barotrauma leading to pneumothorax. Manual ventilation decompresses lungs while preparing for chest tube insertion. Question 29. A patient on norepinephrine at 0.6 microgram per kg per minute has pale, cold fingers, and bluish nail beds. Central venous pressure is 10, mean arterial pressure 70. What should the nurse do first? A. Assess for IV infiltration or extravasation. B. Decrease vasopressor dose. C. Apply warm compresses to hands. D. Give IV nitroglycerin to dilate vessels. Answer: A. Assess for IV infiltration or extravasation. Rationale: peripheral tissue necrosis from norepinephrine extravasation is an emergency. Assess patency and administer antidote, phentolamine, if needed. Question 30. A patient in septic shock has mean arterial pressure 55 millimeters of mercury, central venous pressure 12. Urine output 10 milliliters per hour after fluids and norepinephrine. The provider orders vasopressin. What outcome indicates success? A. Mean arterial pressure increases greater than 65 millimeters of mercury with improved urine output. B. Serum sodium decreases. C. Heart rate increases to 120 bpm. D. Central venous pressure rises to 18 millimeters of mercury. Answer: A. Mean arterial pressure increases greater than 65 millimeters of mercury with improved urine output. Rationale: effective perfusion is measured by improved mean arterial pressure and renal output. Vasopressin restores vascular tone without raising preload. Question 31. A ventilated patient becomes agitated with asynchronous breathing, high pressures, and declining SpO2. Sedation is already at maximum. What is the next best action? A. Prepare for neuromuscular blockade per protocol. B. Decrease tidal volume. C. Call for ABG testing. D. Increase FiO2 to 100%. Answer: A. Prepare for neuromuscular blockade per protocol. Rationale: severe ventilator dysynchrony refractory to sedation requires temporary paralysis to prevent barotrauma and maintain oxygenation. Question 32. A patient in anaphylactic shock after contrast administration received IM epinephrine with no BP improvement. What is the next step? A. Start IV epinephrine infusion and administer high-flow O2. B. Give antihistamine and observe. C. Prepare for corticosteroid administration. D. Obtain ABG before next dose. Answer: A. Start IV epinephrine infusion and administer high-flow O2. Rationale: persistent hypotension after IM epinephrine requires IV administration under monitoring to maintain perfusion and prevent collapse. Question 33. A spinal cord injury patient C6 develops heart rate 38 bpm and BP 70/40. Which action is most appropriate? A. Administer atropine and prepare vasopressor infusion. B. Place in Trendelenburg position. C. Provide high-flow O2 and observe. D. Give IV fluids only. Answer: A. Administer atropine and prepare vasopressor infusion. Rationale: neurogenic shock results in unopposed parasympathetic tone. Atropine treats bradycardia. Vasopressors restore vascular tone. Question 34. A patient with ventilator-associated pneumonia VAP is febrile, hypotensive, and requires increased FiO2. Which nursing action is the highest priority? A. Obtain blood cultures before antibiotic administration. B. Increase ventilator rate. C. Administer fluids and antipyretics. D. Elevate head of bed 30 to 45 degrees. Answer: A. Obtain blood cultures before antibiotic administration. Rationale: in suspected sepsis secondary to VAP, blood cultures must be obtained promptly before antibiotic initiation for accurate identification. Question 35. A patient in refractory septic shock has lactate 7.2 mol per liter despite vasopressors and adequate fluids. Which therapy may improve outcomes? A. IV hydrocortisone administration. B. Administer furosemide. C. Increase PP. D. Give sodium bicarbonate bolus. Answer: A. IV hydrocortisone administration. Rationale: Corticosteroids may restore responsiveness to vasopressors and reduce inflammation in refractory shock. Sodium bicarbonate is not indicated unless severe acidosis persists. Question 36. A post-cardiac arrest patient on a ventilator has PaO CO2 22 millimeters of mercury, PaO2 150 millimeters of mercury, and pH 7.54. What adjustment should the nurse anticipate? A. Decreased ventilator rate to allow CO2 retention. B. Increase FiO2 to maintain high PaO2. C. Decrease tidal volume. D. Increase PEEP setting. Answer. A. Decrease ventilator rate to allow CO2 retention. Rationale. Respiratory alkalosis from hyperventilation reduces cerebral blood flow. Decreasing rate corrects CO2 elimination. Question 37. A patient on PEEP 14 develops sudden hypotension and absent right lung sounds. Manual bagging is difficult. What is the priority nursing action? A. Disconnect ventilator and initiate manual ventilation while preparing for decompression. B. Increase PEEP to improve oxygenation. C. Administer IV fluids rapidly. D. Obtain stat chest X-ray. Answer. A. Disconnect ventilator and initiate manual ventilation while preparing for decompression. Rationale. Findings indicate tension pneumothorax. Immediate manual ventilation allows partial decompression before chest tube insertion. Question 38. A patient in hypovolemic shock after gastrointestinal bleed has mean arterial pressure 48, central venous pressure 2, and heart rate 130. What is the immediate intervention? A. Administer rapid isotonic fluid bolus. B. Begin vasopressor therapy. C. Insert arterial line. D. Transfuse plasma only. Answer. A. Administer rapid isotonic fluid bolus. Rationale. Very low central venous pressure and mean arterial pressure confirm volume deficit. Fluid resuscitation precedes vasopressors. Question 39. The ventilator alarm indicates low pressure and the patient's chest is not rising. What is the nurse's first response? A. Check for tubing disconnection or cuff leak. B. Silence alarm and check ventilator screen. C. Increase FiO2 to 100%. D. Call respiratory therapy. Answer. A. Check for tubing disconnection or cuff leak. Rationale. Low pressure alarms signify loss of circuit integrity. This must be corrected immediately before other actions. Question 40. A patient with multi-organ failure is on norepinephrine and vasopressin but remains hypotensive, mean arterial pressure 55. What intervention should the nurse anticipate next? A. Start low-dose hydrocortisone infusion. B. Increase vasopressin to double the dose. C. Begin nitroprusside drip. D. Administer additional crystalloids. Answer. A. Start low-dose hydrocortisone infusion. Rationale. When vasopressors fail to restore mean arterial pressure, stress-dose corticosteroids improve vascular response by reversing relative adrenal insufficiency. Question 41. An adult on veno-venous ECMO for severe ARDS shows a progressive drop in post-oxygenator PaO2 despite stable FiO2 and flow rates. The nurse also notes rising delta pressure and visible fibrin strands in the circuit. Which action takes highest priority? A. Notify perfusionist for urgent oxygenator exchange and assess for circuit thrombus. B. Increase ECMO sweep gas flow to enhance CO2 removal. C. Increase ventilator PEEP to improve alveolar recruitment. D. Administer additional heparin bolus for suspected clotting. Answer. A. Notify perfusionist for urgent oxygenator exchange and assess for circuit thrombus. Rationale. Declining post-oxygenator PaO2 despite unchanged FiO2 and flow indicates mechanical oxygenator failure from thrombosis. Increasing sweep gas won't improve oxygenation. Prompt oxygenator exchange prevents systemic hypoxia. Question 42. A patient on CRRT with sepsis and DIC develops pink-tinged effluent, a drop in hematocrit, and a TMP, transmembrane pressure, suddenly decreasing. What is the most appropriate immediate nursing intervention? A. Clamp lines and terminate CRRT to prevent exsanguination through a ruptured membrane. B. Slow ultrafiltration rate and observe for bleeding resolution. C. Administer blood transfusion while continuing therapy. D. Check access site for infiltration or bleeding. Answer. A. Clamp lines and terminate CRRT to prevent exsanguination through a ruptured membrane. Rationale. Blood in the effluent and falling TMP suggest filter rupture, allowing blood loss into dialysate. Continuing CRRT risks major hemorrhage and air entry. Question 43. While weaning ECMO flow from 4 liter per minute to 2 liter per minute, the patient's mean arterial pressure decreases to 55 millimeters of mercury, SvO2 to 50%, and lactate increases from 2.1 to 4.8 mol per liter. What should the nurse anticipate as the next step? A. Return ECMO flow to prior support level and prepare for cardiac function reassessment via echocardiogram. B. Administer vasopressors and continue weaning trial. C. Increase ventilator FiO2 and observe hemodynamics. D. Begin inotrope infusion to assist transition off ECMO. Answer. A. Return ECMO flow to prior support level and prepare for cardiac function reassessment via echocardiogram. Rationale. Rising lactate and dropping SvO2 reflect poor systemic perfusion. The myocardium cannot yet sustain full support withdrawal. Reinstitute prior ECMO flow and reassess myocardial recovery. Question 44. A patient in septic shock with AKI is receiving CRRT. The ABG reveals pH 7.12, PaCO2 38 millimeters of mercury, and bicarbonate 12 milliequivalent per liter. Vasopressors are at maximum dose. What is the safest collaborative intervention to stabilize acid-base status? A. Initiate bicarbonate buffered CRRT solution under nephrologist supervision. B. Administer IV sodium bicarbonate push to correct metabolic acidosis rapidly. C. Increase ventilator rate to reduce PaCO2. D. Administer additional fluids to enhance renal perfusion. Answer. A. Initiate bicarbonate buffered CRRT solution under nephrologist supervision. Rationale. In hemodynamically unstable septic shock, rapid bicarbonate boluses may worsen CO2 generation and intracranial acidosis. Buffered CRRT allows controlled correction and stable pH restoration. Question 45. During ECMO support, the oxygenator begins producing frothy pink effluent and post-oxygenator PO2 falls abruptly. Which action is most critical? A. Suspect oxygenator plasma leak and prepare to replace the membrane immediately. B. Increase ECMO blood flow rate. C. Administer a fluid bolus to raise preload. D. Reduce sweep gas to decrease condensation. Answer. A. Suspect oxygenator plasma leak and prepare to replace the membrane immediately. Rationale. Frothy, pink plasma indicates plasma leakage from membrane breakdown, causing gas-blood interface contamination and hypoxemia. Immediate replacement is life-saving. Question 46. A patient receiving CRRT for MODS exhibits high access pressures, low filter effluent, and rising serum potassium. Despite saline flushes, pressures remain high. What is the next appropriate nursing action? A. Replace the CRRT filter and assess for clot burden within the circuit. B. Increase blood pump speed. C. Notify physician to increase anticoagulation. D. Pause CRRT and restart in 1 hour. Answer: A. Replace the CRRT filter and assess for clot burden within the circuit. Rationale: persistent high pressures indicate irreversible filter clotting. Continuing flow risks hemolysis and therapy inefficacy. Filter replacement ensures adequate clearance. Question 47. A patient with ARDS and MODS on FiO2 100%, PEEP 18 centimeters of water, PaO2 50 millimeters of mercury, and lactate 6.0 mol per liter remains hypotensive despite vasopressors. Which action is most consistent with evidence-based escalation of care? A. Prepare for veno-venous ECMO initiation for refractory hypoxemia. B. Increase PEEP to 22 centimeters of water for alveolar recruitment. C. Start neuromuscular blockade and prone positioning. D. Add nitric oxide inhalation therapy as a last resort. Answer: A. Prepare for veno-venous ECMO initiation for refractory hypoxemia. Rationale: failure to maintain oxygenation with maximal ventilatory and pharmacologic support meets criteria for ECMO initiation. Further PEEP increase risks barotrauma. Question 48. While titrating ventilator settings, the patient's plateau pressure rises from 28 to 38 centimeters of water. Static compliance drops to 18 milliliters per centimeter of water, and the nurse notices asymmetric chest rise. What is the first action? A. Disconnect ventilator and manually assess for pneumothorax with auscultation and percussion. B. Increase sedation to prevent asynchrony. C. Increase PEEP to overcome airway resistance. D. Notify respiratory therapy to adjust mode. Answer: A. Disconnect ventilator and manually assess for pneumothorax with auscultation and percussion. Rationale: asymmetrical expansion and rising pressures strongly suggest tension pneumothorax. Immediate manual assessment precedes imaging and prevents arrest. Question 49. A patient on VVCMO with therapeutic heparin levels develops an increased pressure gradient, greater than 80 millimeters of mercury, and progressively darker post-oxygenator blood. The nurse suspects membrane clotting. Which secondary complication must be closely monitored for next? A. Sudden drop in post-membrane PaO2 and cardiac arrest due to gas exchange failure. B. Circuit rupture and hemothorax. C. Air embolism into the sweep gas line. D. Hypovolemia from excessive drainage. Answer: sudden drop in post-membrane PaO2 and cardiac arrest due to gas exchange failure. Rationale: a clotted membrane impairs oxygen diffusion, leading to acute hypoxemia and cardiac collapse. Prompt oxygenator change is essential to sustain gas exchange. Question 50. While on CRRT, a patient suddenly becomes hypotensive, mean arterial pressure 48 millimeters of mercury, tachycardic, and the nurse observes large air bubbles traveling through the venous return line. What is the immediate nursing action? A. Stop the CRRT, clamp all lines, position patient in left lateral Trendelenburg, and call for emergency help. B. Flush circuit to clear air and restore flow. C. Replace the tubing and resume treatment. D. Notify nephrology after securing new IV access. Answer: A. Stop the CRRT, clamp all lines, position patient in left lateral Trendelenburg, and call for emergency help. Rationale: air in the circuit indicates venous air embolism. Immediate clamping and positioning trap air in the right atrium, preventing cerebral or coronary embolization. If you found this video helpful, don't forget to like, subscribe, and share with your fellow nursing students. Hit the bell icon so you never miss an update. See you in the next one. Happy studying.